Hi, everyone. I'm David Glazer,
And I'm Katie Burkhart.
and we're here today to talk about challenging short stay denials, the arguments the RACs don't want you to know. We're trying to do this. I'm trying to stay far away from Katie because I want to avoid being a hospital inpatient or outpatient as she fights through her cold.
And hopefully by the end of the talk, we will be able to determine whether I am an inpatient or an outpatient.
And hopefully you'll be patient with us as I go through a couple of quick announcements. First off, for those of you who were with us last month, an apology. Our vendor has indicated that they had a hiccup that caused a sound problem. And so they apologized profusely for that. And we apologize profusely for it. If you were on last month, you should get an email from us today with a coupon to get a free webinar coming up. So feel free to use that if you want. And once again, our apologies. I will note that was an isolated episode in terms of that was a vendor issue. The internet is a mercurial thing. And so if I suddenly start to sound all choppy, an option is you can use the dial-in number that comes up in the lower right part of your screen. That dial-in number will be coming out right now. Robert will be sending it out. That corner of the screen is also where you can type in questions. And remember, you're always welcome to type in questions in that bottom right corner. And Katie and I are happy to take them on. Our only other announcement are the next upcoming 2 webinars. So in June, Heather Campbell, who's one of our newest health lawyer, she's in our Des Moines office, and Briar Andreessen are going to talk about meaningful use. And the date of that is likely to still be June 13th, but there's a possibility that will change, so we'll let you know. And then in July, we're going to, if the HIPAA regs come out, we'll be covering the new HIPAA regs in July.
We think they're coming.
Yeah,
I mean, we've thought that for about a year, but we really think this time that they're coming.
Speaking as an amateur meteorologist, we know what we think about predicting the future. So, with all that said, let's dive in. I'm going to start off by saying, those of you who have heard our webinars over the years know we've made a habit of being contrarians. We've explained if it isn't written, it wasn't done, isn't the law, and that documentation issues don't automatically result in an overpayment. This is another in that sort of line of situations where we're going to say stuff that's completely contrary to conventional wisdom. And I'm kicking myself for not including my favorite Bloom County cartoon in here. Next time I will. But what we're going to say, I think, is contrary to stuff you'll hear from a variety of sources, but I'm going to bet the farm that it's right. And so we'll walk through it, and if it contradicts things you've heard before, please type us a question if you think there's something we say that's wrong. But this is a situation where I think the conventional wisdom is wrong, and people are refunding and being recouped for money in situations where they shouldn't. And our goal today is going to walk you through how. And one thing that's going to be a little uncharacteristic about this webinar is that we're going to put up more regulatory or manual text than we often do. And that's a little bit boring on some level, but there's a reason for it. It's because we want you to really understand the legal analysis of how we're reaching the conclusion we come to. So we'll be down in the mud a little bit, but I think that mud is going to save you some money. So here's how the RACs view short stays. You know, Bjorg, there's something about holding a good solid mace in your hand. You just look for an excuse to smash something. And hospitals are walking in the door. And our goal, I guess, is to come up with the anti-mace. So this portion of the talk is sponsored by Nair. So this is a short stay background. So why do we care about short stays? It sets up the determination of inpatient versus outpatient stays. You are either admitted as an inpatient or you're receiving services as an outpatient. People regularly talk about observation. Observation isn't a patient status, it's a service. Now, we're going to focus primarily on Medicare, and there are a couple of reasons for that. First, it's the only thing we can talk about that everyone on this phone call cares about. I mean, we've got people in, 25 states, 30 states, 40 states on this thing. And each Medicaid program in your state can have different rules. If you have contracts with private payers, they can have separate policies that they apply. Everyone has to deal with Medicare. And the other reason is I haven't heard about other payers doing much with short stays. Now, you know about the acronyms that are auditing you. I think that going through the acronym soup is sort of silly, but we've got the quality improvement organizations, the Department of Justice, Medicare administrative contractors, zone program integrity contractors, and our friends, the recovery audit contractors, are all auditing on this issue. So, why does it matter? It all comes down to dollars. It's the determination of whether you're admitted as an inpatient and you get a DRG, which is generally going to pay you more than the ambulatory payment classification, or the APC, which the patient, or which you'd receive if the patient is in fact an outpatient. There are other legal differences. Copayments vary. Generally speaking, because there's a separate copayment for each service in the outpatient setting, a patient who's considered an outpatient is going to face higher copayments than a patient who's an inpatient. There's also a difference for SNF eligibility, and since Katie was one of our two SNF gurus, I don't know if you had, but basically, if you Katie, you want to chime in?
So the issue here is that if you are admitted to a SNF after a hospital inpatient stay, but that inpatient stay is switched to an outpatient stay, then your SNF days are not going to be covered. And so it's really critical to figure out what's going on before they go to the SNF.
Yeah, and you have to have a 3-day stay, so if the first part of that stay is considered observation for a day, and then you move over and have a 2-day stay, you'll wind up without your SNF coverage. One of the things that's, I think, intuitively confusing about this is if you can have two patients in the same room getting the same services, and one's an inpatient and one's an outpatient. And that's kind of mind-blowing, because if you think of the goal here as to reimburse you for your actual work, that's one of the things that makes this confusing. Now, the legal background. I use the word mind here very intentionally because I'm going to go all English on you. Mind the hierarchy. Remember, the hierarchy is the statute trumps regulations, which trumps manual guidance. Well, here, it's really mind the gap, because there is no Medicare statutory framework to speak of for what makes someone an inpatient and what makes them an outpatient. That's kind of crazy, because it's a pretty basic and fundamental principle. No statutory guidance to speak of at all. There's some regulatory guidance, and Katie's going to walk us through that in just a moment. And since she's come up with some really creative arguments here and really worked this stuff through, so she's in a better place to walk you through that, so she'll do that in a moment. There is guidance, which appears in the manuals for Medicare, and I'm going to walk us through that. And that's a true joy to review. And remember, in our hierarchy, what Katie talks about, the regulations, trumps what I'm going to talk about, the guidance, okay? The guidance says outpatients are defined lovingly as not inpatients. Helpful and clear. Okay. Medicaid has a very specific regulation that I'll talk about in a moment that gives a very clear definition of what constitutes an inpatient for Medicaid. Unfortunately, or not, that's meaningless for purposes of Medicare. They're different programs. And remember, I mean, people always talk about you can't discriminate, you have to treat everyone the same. That's not true. Not only can you treat people differently, you often must treat people differently. Medicare and Medicaid can have different rules, and when they do, you arguably have to treat patients differently. So we'll talk about the Medicaid regulation, but that doesn't give us any insight for Medicare. Now, Katie's going to talk about the Medicare regulations, which you could say lay out some ground rules, but I think that that's giving them too much credit. I think it's better to call them ground hints. They're going to give us clues as to what the coverage is. And I will now turn it over to Katie.
All right, so before we dive into all this text that we're going to be giving you, I think the best way to boil this down, to think about the issue of who's an inpatient, who's an outpatient, is to consider there being three main questions. First, who is going to decide the status? Is it the hospital? Is it the Medicare contractor? Is it the UR committee? So that's a big question. The second question is, when does the decision maker make that decision? Is it at the beginning of the stay, during it, sometime after the claim has been submitted, when the medical contractor is reviewing it? And then the third question is, how in the world do you make this decision? And basically, what are the standards? What are the criteria? And what the regulations do for us, they do it piecemeal. There are pieces here in this regulation and a couple in a different other regulations, but they do establish that the answer to the first two questions, which is who makes the decision, and then when is the decision made?
In your short answer, who? So who and when?
So the short answer is the hospital, through the treating physician, will be the one who makes the decision about whether somebody's an inpatient. And then the when is the decision's made at the time of admission, when that person presents, not after the admission or not at the end. So the first reg that helps us to get to those answers is this General Hospital Insurance Benefits Regulation, which is basically describing payable days of care in an inpatient setting. And you can see that the orange highlighted text is the important part. You see that the payable day of care includes those where the hospital's provided hospital inpatient services to an individual whom the hospital has reason to believe is entitled to those services at the time of admission. So answers to our first two questions. The hospital is the one who's going to decide it. We're going to have to ask who at the hospital does that. And then you make this decision at the time of the admission. So it's going to involve some sort of expectation or judgment call.
And I think if you printed these out, the first thing to circle is at the time of admission. And we'll come back to this, and we're going to be harping on it, because that's not what happens operatively in the world.
Right. All right, so we get a little bit more specific about who in the hospital is making this decision in the next rule. And these are the rules that talk about how the physician has to certify services. And it's pretty darn clear from this rule that the physician has a major role in making these decisions. In fact, third line down, the physician decides upon admissions. And not only do they make this decision, the physician also has to certify, sign their name to the claim, be responsible for the decision that the services were necessary. So that answers our question of who at the hospital is making this decision. If we go down a little bit further in the certification rules, we get to the certification requirements for inpatient services. And there are three things that the physician has to certify: the reasons for the inpatient stay, the estimated time the patient will need to remain in the hospital, and the plans for what happens after the hospital, if there are any. So again, pointing out that the physician is the one who's making this decision, and then looking at the two terms estimated and plans. And this really supports the idea that the decision is made based on an expectation. It's made at the beginning of the admission based on what the physician thinks is going to happen. Now, the last few rules we talked about were payment rules, and now we're going to jump over to conditions of participation for hospitals, which are a different type of rules, but I think these really kind of bring home what we've learned in the last few slides. So these rules are about the hospital's utilization review committee, and they really emphasize that the physician is really the one who's going to be making this initial decision. And we see that because the only way that you can switch the status through the utilization review committee is to either have the physician agree to it or concur with one member of the committee. And if you don't have that, in all other cases, you have to have at least two members of your committee who are going to override that physician's decision. So again, this is really about the treating physician who's making this call. And if you had any doubt, you see that there is a requirement that before the UR committee makes any decision about that admission, possibly overturning it or changing it, the committee has to consult with the treating practitioner who's responsible for the care of the patient. So they have to go back and basically let that practitioner be heard and tell them the reasons why this admission was proper.
Okay, so now we're going to move over to those Medicaid regulations for just a second. We're not going to spend long on this, but it is useful to note two things. First, it is possible to have a clear instruction, because Medicaid's is pretty darn clear. So they say an inpatient is a person who's been admitted to a medical institution on the recommendation of a physician or dentist and who gets room, board, and professional services for a 24-hour period or longer, or is expected by the institution to expected, and that's an interesting part there, let's focus on the expected, for a longer than 24-hour period, even though it later develops that the patient dies, is discharged, or is transferred to another facility and doesn't stay in the institution for 24 hours. Now remember, we're talking about Medicaid. This is, I would say, of zero relevance to Medicare, but it's good to know what the Medicaid regulation is too, because you might have Medicaid people. And it's nice to note how, I think that's actually pretty clear. And
yeah, it'd be nice if this was Medicare.
Yeah.
And you see the same theme running through this expectation at the time of admission.
So that's a Medicaid regulation. They helpfully define an outpatient as a patient who doesn't stay past midnight. So, okay, blow past that. Now let's go. This is my favorite part of the talk. I have to say, I just love this. So this is what the Medicare manuals, and in specifically the Medicare Benefit Policy Manual, says about who is an inpatient. And what I love about this is we are about to go through 3 different tests that are created in the course of 4 sentences, which I personally think might be a record for setting up different standards in a short period of time. So once again, reading rules is not necessarily the way to do a webinar, but I think here it's kind of important because it'll help you understand the framework. So an inpatient is someone who's been admitted to the bed for occupancy. Let's go to the main important pink stuff. Generally, a patient is considered an inpatient if formally admitted as an inpatient with the expectation that he or she will remain at least overnight. Gesundheit. So that expectation is back, all right? So test 1 right here. We think you're going to stay overnight. You're an inpatient. Notice no reference to 24 hours, all right? So it says, and occupy a bed, even though it later develops that the patient can be discharged or transferred and not actually use the bed overnight. That actually up to here, very similar to Medicaid.
And notice no reference to anything about scope and severity and of illness at all, too.
Right. Okay? So, sentence 1. Now, we actually have a sentence without a standard in the next one. So, the physician or other practitioner who's responsible is for deciding whether they should be admitted as an inpatient. But that gets back to, and I think the way Katie framed it as the who, when, and using what tests, that's a great way to think about it. Well, here's our who. Okay? Now, next sentence. Physicians should use a 24-hour period as a benchmark, i.e., they should order admission for patients who are expected to need hospital care for 24 hours or more and treat other patients on an outpatient basis. Now, I think we might actually have one person on this call from Alaska, but I think that person is still south of the Arctic Circle. Only people north of the Arctic Circle would be in a place where overnight and 24 hours are the same. For everyone else on this call, we've just articulated 2 standards, overnight and a 24-hour period, okay? But if that weren't enough, we have another sentence. However, the decision to admit a patient is a complex medical judgment, which can be made only after the physician has considered a number of factors, including the patient's medical history and current medical needs, the types of facilities available to the inpatients and outpatients, the hospital's bylaws and admission policies, the appropriateness of the treatment in each setting. Okay, first, it doesn't even say, so if there are facilities available, which way does that factor into our analysis? It doesn't explain so far. It just says it's complicated. Oh, and we're going to include things like the severity of the signs and symptoms, hearkening back, and we'll talk more about this in a moment. But
it's probably ringing a bell for a lot of you.
Yeah, so we'll come back to that when we talk about interqual in a bit. The medical predictability of something adverse happening to the patient, the need for diagnostic studies, not really clear. But, so what do we get out of this? Well, 1, there are 3 tests, okay? They're inconsistent. And they're also not, they're in manuals, not in regulations. I'm not going to read you through the rest. I stuck the manual language here for the rest of this. I don't think we need to slog through that because this is not some sort of standardized test. Now I'm going to turn it over to Katie, who's going to take us to yet more manual language and more color.
So we called this additional manual guidance because what David just read from was from the Benefit Policy Manual. And as far as I can tell, that manual isn't really specifically directed at just contractors, kind of lays out the Medicare benefits for whoever's reading it. And this text comes from the Program Integrity Manual, which in its introduction specifically speaks to medical contractors.
And it is probably worth just commenting real quickly, where manuals fit in the legal hierarchy. And that is not entirely clear for a variety of reasons. I mean, they clearly don't have the effect of regulations. And Katie's making an important distinction about who they're targeted to. They're written by CMS, so they are viewed as policy guidance from CMS. Courts have differed. Generally speaking, courts have said, and in fact, CMS has said, manuals aren't the law. I've been in a case where the government has said you rely on information in the manuals at your own peril. So, the manuals aren't the law, and it's important to keep that in mind. They're clearly trying to make them more of a law, and We'll probably have a webinar coming up that'll talk about a new certification requirement where you certify compliance with program instructions. So you can't ignore the manuals, but I think the position we would take is manuals are not the law, and so far the courts have backed that up.
And so we're in this interesting position in this context of inpatient, outpatient, where the manuals are the ones that have the most meat in terms of the standards. So we have to harmonize them with the regulations and then all the different sections. So this paragraph is from the Program Integrity Manual. And we wanted to put this in here because it gives some more hints about the standards, but also we saw in a recent ALJ proceeding, the government really clinging to this particular paragraph and using it to assess inpatient, outpatient questions. And the text that the government's lawyer really focused on is the orange text, which says the beneficiary or the patient has to demonstrate signs or symptoms severe enough to warrant the need for medical care and receive services of such intensity that they can be furnished safely and effectively only on an inpatient basis. Now David's going to talk about interqual, but here you see hints of interqual language, and you realize that people might be likening the two together. What I want to point out is the blue text, which arguably sets forth a looser standard, I think, than what we've talked about before, where the decision is made at the time of admission. The blue sentence just says, review of the medical record must indicate that inpatient hospital care was medically necessary, reasonable, and appropriate for the diagnosis and condition at any time during the stay. So this almost makes it easier to make somebody inpatient, because even if maybe they weren't an inpatient at the first when they presented, if at any time they needed inpatient services, I would maybe point to this as support for the fact that then the whole thing should be inpatient. So it's just interesting the variation in standards that you see, and David's going to talk a little bit about harmonizing all of these. Oh, this is continuing on the paragraph. A good point here is just to note that the guidance is saying that you can't just make somebody an inpatient because it's inconvenient for them to go home. But on the flip side, if it's unsafe for somebody to be in their home, then that would be an argument for why they should be an inpatient. And then the last sentence points you to right back to the text that David first talked about with the 3 tests. So it's clear that there's been this effort to harmonize all of the guidance, and I would say that the main tests will be in that benefit policy manual section that David talked about.
All right, so the next thing we're going to talk about is the treating physician rule. And the treating physician rule, those of you who have been frequent listeners of our webinars, you've heard this before. It's a concept in Medicare that we want to defer to the treating physician because it basically came out of the legislative history when Medicare first came out. Everyone was talking about socialized medicine and how this was government taking over healthcare. I had one of those deja vu moments just now. I don't know where that came from. But government is taking over healthcare, and so as part of the preamble when Medicare came into being, they said, no, decisions continue to be made by the physician. And so here are just 2 cases that cite this principle that the physician is the key figure to figure out how services are utilized. The opinion of a treating physician gets extra weight. I often call it the tie goes to the treating physician test. It's sort of like, because it's baseball season, if 2 physicians could offer an opinion, if the treating physician's weight carries the day, as long as it's in the realm of reasonableness. So this treating physician rule, we think, can be bootstrapped into the short stay analysis by saying the treating physician's judgment should get deference, and if he or she thinks that the patient should be an inpatient, they should be an inpatient. And a lot of the text, the regulatory text that Katie talked about, and remember, Katie beats me because she's got regulations and I only had manuals. Her regulatory language also talked about how the physician makes that test. And so this is just further support for it. Now, this is something that's useful. Put this in the back of your mind, not just for short stays, but for any medical necessity fight. There's some language buried in the claims processing manual that is, I think, frequently overlooked. And this language is discussing when potential overpayments should be waived because the provider of services is without fault. And it sets up a test that basically says if the carrier is recouping money because of medical necessity, and the framework is ambiguous and the carrier needs to have a physician review the situation, they're not supposed to recoup an overpayment. They're supposed to just say, you shouldn't do this, and not take the money. I'm slightly paraphrasing, and I've included the actual language right here in the next two slides, the text right out of the manual. So it basically says, this is a situation where you have evidence that either the provider or the practitioner is without fault. And it happens when you've got a treatment that's only rendered by a physician, the contractor hadn't denied the treatment before, and the contractor asks for its physician reviewer to look at it. So here's the language. You can just sort of put this in the back of your mind. This isn't perfect language for short stays, but it's something to keep in mind for all situations where you're trying to deal with ambiguous medical necessity situations and you want the judgment of your physician to carry the day. So I think that's enough on that one. So how do you harmonize the manuals? Well, the judgment of the treating physician should carry the day. And I'd say if at the moment the treating physician is seeing the patient, they think the patient is going to spend the night in the hospital, you've got a reasonable argument, a far from embarrassing argument, that that person's an inpatient. Okay? It's not a absolutely 100% guaranteed because of the multiple tests in the manuals, but I feel pretty good. Let's put it this way. I'm going to argue it, and I think I should win it. If the doctor thinks the person is staying 24 hours...
Even better.
Much better. I think then you got a winner. I mean, I think, and actually overnight, I can't see how someone says overnight based on the text in Section 10 of the hospital manual. I don't know how someone toasts you because you're reading right out of the program instructions what's there. What the government would have to do is come back and argue, you can't rely on our manuals. And as I said, they've done that to me before, and they're not beneath making that argument. But if I'm not going to give that money back voluntarily. Let's put it that way.
And the government has its own problem of trying to figure out what exactly they're going to use for the standard, because they'll pull theirs from the manual too.
Amen. So you are now in a position, you need to figure out how are you going to review your short stays. There are the Pepper reports, and I'm not a Pepper report guru. In fact, when I hear Pepper report, those of you who are younger than me aren't going to understand this at all. Those of you who are older, I think of Senator Pepper, and I think it's Claude Pepper is immediately who comes to mind. But Pepper reports that can tell you utilization, not that, being atypical isn't proof of a problem. You may be the highest user of short stays. That doesn't mean anything you're doing is wrong. It's worth knowing because, yes, it does mean you're likely to get audited, but it's just like the E&M stuff we talk about. Someone is going to be the highest in the state. That doesn't mean they're doing it wrong. It may mean that they get audited and have to defend what they're doing, but it isn't wrong. So look at your Pepper report data. A whole bunch of people are selling reviews. UR committees look at this stuff. And now let's talk Milliman and Interqual for a moment. So what is Interqual? Hello, Emily. This is Gladys Murphy up the street. Fine, thanks. Say, could you go in your window and describe what's in my front yard? I sort of feel that way about Interqual because, darn, it's hard to figure this puppy out.
And it's supposed to help you to figure things out much more easily.
Yeah, and I apologize, McKesson. I know you're trying to do the right thing, or at least maybe you are. You at least come up with a profitable business line. Boy, I find Interqual to be confusing. And this is a super important point. I'll do a stage whisper. No one reads Interqual. And I'll come to that in just a moment. But I think no one actually understands. I shouldn't say no one. Very few people understand how Interqual works. So there are commercial tools that people sell to help you figure things out. Exactly as Katie said, the two biggest I know about are Interqual and Milliman. You're not required to use them. In fact, I'll go a step beyond you're not required to use them. I'll say the standards that they use to do a review are inconsistent with what we've talked about to date. Interqual focuses on two phrases, intensity of service and severity of illness. So it's IS and SI. And I mean, I'm sorry, really, you couldn't come up with other letters, is and C, but okay, that's the framework that they use. The closest we had in the manuals was, what was it, severity of symptoms? Is that
severity of symptoms.
Or severity of signs,
and
maybe?
Intensity of I guess intensity of services is the closer one,
Yeah.
but the severity of illness is not.
But I think it's severity of symptoms,
right,
I believe,
right.
is the phrase. So it's close, but certainly not the same. And whenever you're doing an intensity of service, severity of illness review, you're doing it on services that are provided to the patient in the hospital. And remember that Katie explained to you that the test is being done at the time of admission. So if you were to do a true ISSI review, and that were the proper standard, under the manuals, the best that, or the time that would be applied would be saying, when you do the admission, do you think that level of intensity of service or severity of illness will exist? As soon as you start doing it based on services actually provided in the course of the hospitalization, you've stepped away from the instructions in the manuals. And hopefully that's making sense.
And it's interesting because we've seen the government use this idea of looking at services provided after the patient is admitted. But it's important to remember that the manual itself, I'm forgetting which manual, but it says, government says, we don't use an industry screening tool. We don't prefer one over the other. And so just keep that in mind.
Yeah, that's a very important point. You don't have to use them. In fact, those of you who are lucky enough to be in the kyphoplasty case, a case near and dear to my heart, may know that the U.S. attorney who's running that investigation has, for lack of a better term, scoffed at interqual and said, I don't care what interqual says. It's meaningless. Now, that's not really true either, and the reason we know that is that there was a settlement in 2001 involving a hospital in Georgia called Meadows Regional Hospital, and as part of that settlement for an investigation of short stay cases, one of the conditions of the settlement was that Meadows Regional use interqual going forward to review their short stays. And in fact, many QIOs either specifically specifically instruct hospitals to use interqual as a tool to review. So I think if you choose to use interqual, you can, and I think interqual provides you really good cover for if you've relied on interqual to determine someone's an inpatient, I'd feel very strong defending that decision. But I think it takes you to the wrong place, and this is what I want to elaborate on a bit. This is back to the few people seem to actually read interqual. The kyphoplasty case is really interesting because people are coming in for scheduled procedures, and all across the country, hospitals are doing claim-by-claim reviews of the level of care provided to patients who came in for this procedure. And companies are making a boatload of money doing these reviews. And I think that that's all a sham. I don't think that any review is supposed to happen. And the reason I feel that way is that when you read interqual, interqual breaks patients into two buckets: scheduled admissions and admissions that happen through the emergency department or the emergency room. And interqual's tests are different. Basically, and get your reading glasses out, I apologize for a few things on this slide. First, yikes, just look at it. Second, this is actually a 2005 copy of interqual. I don't have the current copy, and I'm kind of lazy, and this is the copy I had for working on the kyphoplasty case. But if you look at the right side here, it sets up the pre-admission review rule. And the pre-admission review rule, if you look at the middle of the right column, is you go to the list in the surgery trauma, and you confirm that either the admission date is the same as the date that the procedure is being done, or the patient is at high risk for thromboembolism, or the admission date is the same as the C-section or induction date. And if that's true, really what you're doing, then they're being admitted for this procedure, and you look at whether the procedure's on a list. By contrast, the future pages of the book talk about how you handle admissions when it's being done out of the ED. And that's where you see their IS and ISI stuff on the right-hand side of things. So if you're got a scheduled procedure, you don't apply any of it, even if you choose to use interqual, the whole intensity of service, severity of illness stuff goes out the window. Instead, you look at a list and see if the procedure involved is on the list. I would note, just if you can squint on the right side, you will note that if you don't meet the SI and IS test, the first thing it says is obtain additional information from the attending physician or other caregivers. And if the additional information doesn't meet the ISSI tests, discuss alternate levels of care with the attending physician. Facilitate transfer to the attending to a different level of care if the treating physician is agreeable. This is setting up still deference to the physician's judgment. This is not a, if you don't meet the tests, you're out of luck. And I don't think that's how interqual gets used in the real world at all. Now, to emphasize again, I think interqual is kind of wrong in the sense that it's applying a test looking at what's being done to the patient, and all of the instruction talks about making a decision at the time you're determining whether the patient is an inpatient or not. And those are totally inconsistent, and I recognize everyone does it this way. I just think they're all wrong. Okay, so this one is in here purely to illustrate kind of how interqual works for people who are going, what the heck is interqual? You know, you have clinical findings and imaging findings. So this is out of the surgery trauma section of the book. And, you know, here you have to have one or more thing on this page, you know, to get on. And so the reviewer is just going to go through and they're going to look. And if you've got an amputation of a limb traumatic, surprisingly, that gets you as an inpatient. You know, if you have an aneurysm that's greater than or equal to 4.5 centimeters, so you just look through this book and you're looking to see if you meet these tests. It's pretty mechanical. And this list, if you really squint and look at the right side, you'll see on the right side, second from the bottom, is kyphoplasty on the list. And it's on the list as something that should be done as an inpatient setting. And here the government is investigating a whole bunch of people and saying it should be on the outpatient side. And I think they're all wet. All right, so let's talk about two quick examples. Patient shows up with chest pain. They've got an elevated troponin level, and so that's suggestive of a possible heart attack. The physician wants to observe them for 36 hours and figure out what's going on. The trick word there is observe. And so a bunch of people would say, well, we're just monitoring them. We're observing. This should be observation. And remember, again, observation isn't a status. Observation is a service. So what they really mean is that they should be outpatient. I disagree, because the physician at the time that they're making the decision thinks that they're going to be there both overnight and, more important, and for more than 24 hours. I think under the manual guidance, this person's an inpatient.
Yeah, this is really a good example of where semantics it's important to talk with your physicians about what they're communicating to the billers or the people who are admitting the patient, so that it's clear that the physician isn't putting them in observation, but rather wants them to be an inpatient.
And we'll have some tips on that in just a second. So another example. Patient's had a procedure. They're slow to wake up after this planned procedure. The doctor wishes to keep the patient overnight and observe for complications. Now, overnight, as we've talked about, isn't as crystal clear, but it's in there. It's one of the tests. I mean, actually, I don't know why I'm getting all wishy-washy. You've met one of the tests in the manual. You know, from a risk management standpoint, could someone choose to call this an outpatient? I suppose you could, but if you'd call it an inpatient, I feel comfortable taking this case. Now, Katie's going to talk about something a bit different, one of our favorite confusing terms, a condition code 44.
All right, so this is the situation where you admitted a patient as an inpatient, and for some reason, you want to switch the status because you didn't think that admission was appropriate. Now, hopefully, we're giving you some tools that will allow your process to go more smoothly so that you know when the treating physician wants inpatient admission, and then you don't need to go through this. But obviously, things come up, and sometimes statuses must be switched. So what CMS has done is created this strange little process called Condition Code 44. And I'm going to kind of harp on it, but I will say, try to use this process because it will help you avoid getting into a fight with the government. But if it doesn't work, you can't meet Condition Code 44 process, then there's still hope for you, which I'll talk about in a minute. So this is a process created by CMS for what they consider should be very infrequent occasions when somebody came in on the weekend and people weren't able to evaluate properly whether they should be an inpatient, and that patient is still in the hospital. So when that happens, there's a narrow set of circumstances for Condition Code 44 where you can switch the status, but these are what you have to meet. You have to change the status before the patient is discharged. You also have to change it before the hospital's submitted a claim. And this is a criteria that I didn't realize was part of Condition Code 44 until recently. The practitioner or the treating physician who's responsible for that patient has to concur with the UR committee with the decision to change the status. So query whether what happens when the treating physician is firm and clear that the admission was proper, and then the UR committee disagrees. There's not really a solution for that in CMS's mind. So you have to have the two concurring, and then you have to document the concurrence. So pretty narrow window of time for you to switch this and not run the risk of Medicare not paying for anything. So just simple billing instructions, make sure you use code 44 on the outpatient claim, and then there are some more documentation requirements later on in the manual, so make sure you have these two to sort of bolster your argument that you did this the right way. There's this weird section in the Condition Code 44 guidance that I read, and I walked onto David's office, and I said, what does this mean? And he read it, and he didn't really know either. So
it's always validating for me because I often feel stupid and Katie can dig me out of trouble. And so if I had read this and on my own, I would have felt frankly like an idiot.
So it seems to be some sort of way that CMS is saying, hospital, if you had to switch statuses, you can still be made whole or somehow account for the time in between the admission and then the decision to switch the status to observation. And while you can't bill that as an observation claim, you can report the charges on the claim for the costs of the resources that were used during the care of the patient during that time frame. And I don't know why you would do that. That's the orange language that I'm talking about.
Yeah, and I guess the question, what we can't figure out, is if you're including the charges, if what they mean by that is in a way that it gets recorded in cost data, and so it goes into the kind of future payment rate setting equation, or if they're saying in some way you get paid for it, because if you're not, if you're not getting it as an observation service, I'm not understanding how you'd get paid, and so including the charges doesn't necessarily mean to me reimbursement. But this is where my pea brain can't figure this out.
And this is the continuing section on how you actually do this. So you do this on an uncoded line, and you have this special code 0762. And this is how you do this. So I'm hoping this is helpful to those of you out there who are smarter than us. And if you do understand how this is supposed to work, we would love to be enlightened. But this is sort of the only stretch or give that we get for Condition Code 44 from CMS. Now, do not despair, because there's a recent 2 years ago, recent in that people are just sort of talking about it now. There's a recent case before the Medicare Appeals Council, and that's, just so you understand the levels, that's the level after the administrative law judge, and then the next level is district court. So this is a pretty high agency level. So what happened was O'Connor Hospital challenged Medicare challenged 4 of their inpatient admissions, and they got up to the ALJ level, and the ALJ said, okay, well, 3 of them were actually medically necessary. The 4th one wasn't.
And I'm just going to interject to say that's exactly what the statistical average, I think, on these RAC appeals is. It's like three quarters of them get reversed. So
don't be afraid of challenging. So on the 4th case, the ALJ actually said, well, you didn't meet the inpatient medical necessity, but you did meet the criteria for observation, and you should get paid for that Part B payment. And obviously the hospital here didn't use Condition Code 44, so they were looking at not getting paid at all once the RAC reversed them. So the good news is that the Medicare Appeals Council agreed with the ALJ, which is really great, and they basically took, in getting to that conclusion that the hospital gets the Part B payment for the observation services, they basically pulled together a number of manual sections that stand for the notion that Medicare contractors have the ability to pay Part B when Part A inpatient admission is not met. It's not that hard, basically, is what the appeals council was saying to the contractor. You guys can work with the provider to see if they should have been paid for Part B, and then you should pay them for it. So this has really been a big deal in the short stay world because CMS has always talked about this policy that they've had since the 70s. This is from a recent conference David and I were at, and you had CMS officials talking about this issue. Their policy is that they don't pay Part B, or they pay it as little as possible in the inpatient setting. And then you have the Medicare Appeals Council saying, no, that's actually not how it should be. So what CMS has said it's going to do, basically in response to this, is to have a demonstration project to talk about whether they can actually handle the rebilling of the Part B services. So keep an eye out for this, and definitely keep O'Connor in your back pocket because it's really strong, powerful tool.
And while we're talking short stays here, it is worth thinking about, because this comes up a lot right now in all kinds of overpayment and voluntary disclosure situations where you have the question, which is you're past the timely filing requirement. Here what they're saying is the timely filing is by the time was when the patient's discharged.
Right.
So, but in other situations, you're a year out, you've discovered you billed an X and you should have billed a Y. What do you do? And increasingly, the MACs are saying, sorry, you're out of luck. You don't get to rebill, so you have to refund what you gave, and you can't keep any additional money. And our experience has been that almost never carries the day when you get in front of a judge. And O'Connor is his principle for short stays, but in other settings, and it stands for the principle, you can offset what you should have been paid from what you were paid, and that's the overpayment. And it's common sense, and it seems to, in fact, be the law. Okay, we are coming into the home stretch here. We're just going to do some practical tips for kind of risk management and appeals. If you've got questions, we've got at least one I know I've seen, but this is the time to send them because we'll, and characteristically for Katie and I, perhaps end up earlier on time here. So the practical tips are pretty straightforward, actually. This is a situation where there are magic words. If the doctor says, I expect the patient to remain at least 24 hours, I think you're golden. The next practical tip, I think, I like to be inflammatory, and I'm about to be inflammatory, especially because I'm going to talk about book burning, which is flaming. I think we should burn all of our Interqual and Milliman books. I mean, and that's over the top, but the manual languages should be what we're focusing on, especially right now for purposes of deciding whether you're voluntarily refunding money or whether you're fighting an overpayment. I don't care whether you meet Interqual or Milliman. I care whether the doctor, when they admitted this patient, thought they were going to be there overnight or be there for 24 hours. If the doctor will say yes to that, I'm fighting this puppy. And, Katie said it, I'm going to say it, it's expectations. It's not about what actually happens. We don't care about the course of treatment once the person is admitted. That's irrelevant. And that makes the reviews way, way cheaper.
And I think what you'll see the government argue often is, well, this person had an uneventful stay, and therefore they should not have been an inpatient. Again, what happened during the stay is not the question. It's what was expected to happen during the stay.
If you can make a status determination while the patient is in the hospital, that's the way to go. I think it's kind of enough said. I mean, it can be problematic, but if you can do it, that's lovely. Remember, aberrancy isn't illegal. I think I've already made that point. And I think you already know, admit to observation is not a phrase that moves the ball forward at all. So, which brings me to what you could call the elevator speech. I'm going to, there's a famous Talmudic story about a guy who walks up to a rabbi and says, Rabbi, teach me all I need to know about Judaism while I'm standing on one foot. And I think that can be a useful, it's the, I guess that was before elevators, the equivalent of the elevator speech. This is a good way to think about training people because I think you can train your doctors at the beginning of a medical staff speech and you can do it in 90 seconds. Here's the speech you give to physicians. Doctors, there are only two statuses, inpatient and outpatient. If you think the patient's going to stay overnight, you can probably call them an inpatient. If you think they're going to stay 24 hours, you definitely should admit them as an inpatient. In your order, you want to say that you expect the patient to stay 24 hours. Oh, one more thing, doctor. The government likes to claim that doctors who make mistakes ordering services have caused a claim to be presented. And so if we get into trouble for screwing this up, you might be on the hook with us. There's our elevator speech. And it's not that, I mean, it's funny because it avoids all of this intensity of service, severity of illness, gobbledygook, and goes to an easy, articulable standard.
It's so short it could be a Facebook status.
Wow. Now see, Katie is hip and I am.
Moving from elevators to Facebook.
Yes. And now Katie's going to walk you through some appeals tips from things we've learned in some of our appeals.
All right, so again, these tips are pretty practical. They seem fairly obvious, but important fundamental things to think about. So if you're being hit with an audit, right at the beginning, pick the team who's going to be working on this and make sure you know who the internal people are, and if you're using outside counsel, get them in the loop early. And the reason for that is because you want to know your story, and you want to stick with it the whole time so that it's effective, easy, and cost efficient. Now, David's going to comment a little bit on this. We suggest using one physician for all of the appeals, and I wouldn't necessarily even suggest using the treating physician.
Yeah, and this is an interesting point. I don't know if I'm wrong on this one, but kind of my belief is that there's an advantage to having a physician who doesn't necessarily have skin in the game, that he or she didn't make the decision. I mean, there's an advantage to using the treating physician. The advantage of the treating physician is they can say, I expected this person to stay. But I think focusing it, first of all, if you have 6 of these things, you don't want to get 6 doctors in to testify. It just isn't practical. So part of it is that practical side. But I think it's useful to get one physician to train them so you can get them to get used to the testimony and to say the right things, because actually where these things go wrong practically in the appeal is often in a physician sort of wandering off in a direction that you didn't expect. And so a lot of this becomes witness prep, and it's easier to train one physician. And then you need to make sure that that physician sees the cases early on. I know Katie just did one of these where the doctor, wasn't involved early on and suddenly went, I'm not comfortable with the way these cases have been postured. So but I think from a practical level, if you can use one physician, I'd go that route and kind of have that person be your expert's not exactly the right word, but your kind of professional presenter.
So once you know who's going to be involved, you want to figure out your story and base your story or your case on the manual language that we talked about. Keep it simple, make it the outline for both your appeal letters that you're submitting at the different levels and then for your testimony once you get to the ALJ. And then at the ALJ level, we've found that it's easy to get, as you can see from this talk, it's easier to get mired in the details about the different manual sections and the review policies of CMS and Condition Code 44, and there's just a lot going on. So make sure that you keep the focus or bring back the focus to the tests. Who makes the decision? The physician. When? At the beginning of the admission. And what standards? Well, we have a number of standards that all appear to be useful from the manual language. So keep your story short.
Okay, first question. So I think this was a question for you, Katie. We billed for the services. I'm going to paraphrase this one a bit. So we billed for the services, and we now realize that the person should have been an outpatient. Can we, do we have to refund the whole claim and rebill it? What do we do?
Well, this is the O'Connor case where you at least, sorry, I'm forgetting the question here, where you at least are entitled to the Part B payment for observation services. So I would not refund the entire thing, but rather the difference between the observation and the inpatient stay, because there's law out there that we talked about that says you're entitled to the Part B payment if you provided those observation services.
I think this one might be for me. Can we comment on the applicability of the carrier manual citation to hospital claims reimbursed by the intermediary? If I use the phrase carrier manual, I was living in the past, because actually the manuals here are the benefit policy manual, and I'm trying to think of what other manuals we have floating around, but all of the program integrity manual, all of the language we're talking about clearly should apply to the intermediary / MAC on this. So this language is clearly applicable and relevant.
Okay, this is a good question. This person asks, are there strategies that organizations have used to mitigate the costs associated with appealing erroneous denials, particularly high volume, low reimbursed, automated denials based on faulty methodology? It's a really good question. We're seeing the RACs, and this isn't just limited to short stays, but automated denials where the RAC thinks they're following some policy and then it's the wrong policy, but they just deny on an automatic basis. And it's really crummy situation. I think, the tips we have are get on top of it quickly and make a form letter that you're using so that you can send that in every time you get one of these denials. David, I don't know if you have any more.
Well, I'd say just a couple of quick things. One, we've sometimes trained people internally in an organization on methods to do the appeals, and you kind of focus it on some people, and you can have kind of the lawyers supervise but not do all of it. And especially if it's repetitive, that can work really well. I am a fan. I had one client that tried we're appealing every one of these denial strategies, and it worked really well. They stopped getting audited after a while. I don't know if that'll always work with the RACs, but they won. And if you viewed it on a short-term cost-effective basis, it wasn't cost-effective. I mean, I spent a week doing appeals that the value of the appeals was probably measured in it was under $10,000. But that was the last time we did it, and then it stopped. Okay, I haven't even read this one yet. So let's go with one of these. So what are your recommendations to facilities when ALJs dismiss cases for timely filing, even though the RAC reopened the case? That one's a tough one. I don't know if I understand enough of that one to do it here. So I would say call Katie or me, and we would be happy to try to walk you through this one. I have here something about sound cutting out. I'm hoping that was isolated. But go over the billing for services provided in observation after status is changed to an inpatient. I'm hoping that the sound only cut out for that one person.
Well, I don't know if this person is asking about that weird paragraph about Condition Code 44, where there seems to be some sort of method where you can report the charges for the services provided prior to observation. But unfortunately, that's something we're still trying to figure out if that's even a way we can get money for those services.
Yeah, and if you've got questions, first I apologize. I'm hoping the lunch hour is cruel to the internet, and so we do occasionally have some slowing. I can't believe this, but I think we may be out of questions. So to wrap up, possibly June 13th, and certainly sometime in June, we'll have a meaningful use webinar. Please do your evaluations, and we're really interested in topics that you're interested in. We've gotten some really good suggestions. I don't remember if short stays. I think this might have actually been Katie's suggestion, but we like suggestions, and
hopefully this helps you to feel more empowered about this issue.
Yeah.
Because I think this isn't rocket science, and they're good tools.
And I'm going to put in a plea: fight these things. This is my mantra for this year: is the government is going up and down streets lifting car door handles to see which car doors are unlocked. And if the door is unlocked, they take your spare change, they take your CDs. And there are people who say, oh, I don't want to lock the door. If I lock the door, the government will smash the window. That's the don't fight this stuff, just give in. Well, I understand that instinct, but A, they don't smash that many of the windows, and B, if they're going to take all of your money out of your car anyway, the window isn't that much worth that much more. I think, it's if you get caught having billed for something, you shouldn't refund the money. But on this short stay stuff, I'm seeing situations that are quite appalling. I had one I remember very vividly. It was an 87-year-old woman who was in the hospital for 3 days with symptoms of a stroke, and the RAC tried to argue that was observation. No way. I mean, it was a 3-day stay as they were trying to figure out what was going on, and she was dehydrated and a whole bunch of things. This was a relatively sick woman, and they were trying to figure out what was wrong with her. We got to fight these. So I'm off my soapbox. Thanks for joining us, and we hope we see you next month.